Hi, good afternoon, everyone. Welcome. Today we're talking about shared decision making, and it's something that um, I've been doing research on in some form or another for over 25 years. I'm uh, an associate professor at Yale, the Yale Program for Recovery and Community Health, and the director of research and evaluation there. My research really started, and I hate to say it, 25 years ago, with topics of advanced directives and, self-determination. And these concepts have really evolved over the years, and now we're hearing much more about shared decision making. And as I was preparing this talk, I was thinking, um, I know the origins and understand the history around advanced directives and self-determination, but understood less about the term shared decision making and where it came from and how it has been used or evolved over the years. So I did some sort of lit review and looked at what I found was these are citations that used the term shared decision making in the title of the articles going back to 1964. And as you can see, there are a few, this is about one or two per year back here. And right around 2010, there was just an explosion in our research and literature and publications on shared decision making. What's interesting, or what I found interesting, was when you look back here in 1967, that was the first journal article that I found. And it really talked about shared decision making were models in education and in organizational management. And shared decision making had to do with principals sharing the decisions about school activities with teachers. In organizations, it was about management sharing decisions about the activities of the organization with subordinates. And so really it was a way of key stakeholders, individuals who had a stake in the organization or the school, providing some input and being asked to provide input into what's the decisions that are made around that institution. When you look here, in 1980, President Carter commissioned a study of ethical problems in medicine and biomedical and behavioral research. And in this study, one thing that happened just before that, that's not on here, but in 1975, I don't know if you'll remember the Carol Ann Quinlan case that had to do with a person's right to have dignity in death and to not be have their life prolonged if it was inconsistent with their wishes. And so around this time, there were a lot of discussions in medicine around people's rights to have a say in what they don't. The doctors typically are the sort of educators. They're the ones that have received all of the training and knowledge. And people, as patients, typically were seen as consumers and people who looked to the doctors to provide the recommendations, but weren't really an active partner in that. In 1982, this commission released a report called Making Healthcare Decisions. And in this report, they actually specified that individuals need to have say in their healthcare, and particularly when the options may be sort of ambiguous in terms of outcomes. So this was kind of the first time a national board had said people need to be involved in their healthcare decisions. In 1990, we had the Patient Self-Determination Act that actually codified the laws for individuals to be able to create advanced healthcare directives where they were able to say in advance, this is how I want to be treated if in a time late in the future I'm unable to express my wishes. The other thing that was happening in the early 1990s is that medical societies and government panels began recommending that patients be given more information about the options and allowed to make a choice based on their personal preferences. Also in the early 90s, what was happening was we had the internet. And so individuals had access to a wealth of information that previously was more difficult to access. And so people were coming into their providers and saying, well, what about this? What about that? I read about this. And as you know, that's a very common part of our healthcare system now today. But this is where this sort of exploded in the early 1990s. And the other thing that happened is the research was ambiguous about particular options. There was no clear evidence in some cases about which decision or treatment option would be best. And so in those cases, that's where they began recommending that it should be in line with a person's preference. We had the 2003 President's New Freedom Commission report that really mandated that all care needs to be person-centered and involving the choices and decisions of the individuals involved in the treatment of the patients. In 2010, there was a Salzburg statement, which was a group of 18 different countries. So internationally, they said that people have to have a say in their healthcare, and they have the right to have that choice. We also had the Affordable Care Act that came in and the development of PCORI, the Patient-Centered Outcomes Research Institute, that really focuses on sort of how to include and involve individuals in the healthcare decisions that are being made. If at any point you have any questions or I'm going too fast, please put them in the chat. I have Janice here will be monitoring the chat and will help sort of guide me towards that if we need to. And speaking of Janice Tondora, who is my colleague and fellow expert in person-centered healthcare, if you were able to see her presentation a couple of weeks ago. So I'm thrilled to have her with me. We have really worked on this together a lot over the past 20 years. And in particular, when I get to our framework, our other colleague, Anthony Pavlo, and Janice and I have really thought about how to combine a few different areas of research into something that we think is really exciting. So just the main thing about person-centered healthcare is that shared decision-making is probably one of the most, if not the most important element of a person-centered healthcare system. That you cannot have a person-centered healthcare system without shared decision-making. And this is where the Institute of Medicine also came out in 2001, that care needs to be responsive to patients' preferences, needs, and values. And PCORI also said that person-centered care is inclusive of individual preferences, autonomy, and needs, and focusing on outcomes that people notice and care about. So as you see here in the person-centered sort of literature, there's a lot of talk about preferences and values and hopes. We find that some of the research that show that studies that are informed by and tailored to individual patient preferences are associated with greater engagement in treatment, improved therapeutic alliance, increased patient satisfaction, and improved outcomes in care. I'm not going to go into a lot of the other research. I think it'll come through as we continue on, but that's that. So back to kind of shared decision making. In 2019, there was a review of shared decision-making models, and this review identified 40 different models in the literature of shared decision-making. And some of them had some common elements, but there's also some that are very unique. One of the issues with having 40 different models of shared decision-making, and one thing that the literature talks about and that we have found, is without the consensus about what is shared decision making, there's a lot of different views on it. It's really hard to know how to implement it in practice. When you looked at some of the shared elements, 88% of these models had some element of describing treatment options, talking about benefits and risks, providing some evidence, the feasibility of the options. 75% had an element of about making decisions, actual documenting the decisions and revisiting it afterwards. 65% referenced something about patient preferences, and mostly in terms of their concerns, their goals of the care, and their values. 65% talked about tailoring information to the patient. 58% had a deliberation or some element of negotiation. And 53% of the 40 models had elements about learning about the patient. So I'm just going to pause there for a second and see if there are any thoughts or if anything strikes you about that, about these models. If so, please go ahead and put it in the chat and we can have a discussion. If not, I'll continue. So in terms of the models, there really are 3 or 4 kind of primary models that many of these individual models kind of are based upon. The first one here is the SHARE approach, which you might be familiar with. This is from AHRQ. And this really involves 5 essential steps of decision making. First is to seek your patient's participation. Second, help them explore and compare the treatment options. Third, you assess your patient's beliefs or values and preferences. 4, you reach a decision. And 5, you evaluate that decision. Sounds pretty simple and straightforward, right? Another model here is the team talk, and this is Elwin's team talk. It's the 3 talk model by Elwin. And it starts with working together, talking with as a team about choices and support and goals, having some active listening, doing some talking about different alternatives and options. There's a process of deliberation and then making a decision. And finally, one of the most common models is the Charles models from the late 1990s. It really talks about shared decision making on a continuum between informed decision making and paternalism. Informed decision making being the ethical sort of practice of making sure that a person is informed of all the risks and benefits, that knows what they're deciding and consenting to for treatment. And paternalism being where a provider or a medical provider actually makes the decisions largely for patient without much consideration of the individual's values. One thing that's important to know is that in all of this, involving individuals in decisions about care is not just asking people what they want, but it involves a process of providing people with accurate information about what options are available and engaging with them in a process of weighing the risks and benefits and having them decide the course of action that is most consistent with their preferences, goals, and values. And I'm going to just reiterate that last part again. Identifying a course of action that is consistent with their preferences, goals, and values. I want to think about this for a second and just have you reflect about maybe a recent medical appointment that you had or an experience that you had. Most doctors, when they're going through their training, they have a really in-depth understanding of their medical practice and of medical decision making and the different options. They've spent years focusing on this. What the research has shown is that most people, and when we look at like advanced directives and people being able to write and express their preferences, values, and goals, most people aren't comfortable doing that. Most people do not have an advanced directive. And one of the main reasons is it's hard to think about what's going to be most important to you in your life at some point in the future. you may know now, but it's also not something that we spend a lot of time, typically, most people don't spend a lot of time articulating and expressing their preferences, goals, and values. It requires some thought. We're thinking about preferences, goals, values. And when we think about shared decision making here at our program, and with Janice and Anthony, my colleagues, we're thinking about a value-centered framework. And value-centered means kind of starting with an individual's values, hopes, dreams, and goals, and not values, hopes, dreams, goals, preferences for treatment, but values, hopes, dreams, goals, preferences for life. What is most important to you in your life? What do you value? What gives you hope? What gives you purpose and meaning in your life? And then the medical experts will bring in all of their knowledge, and in combining these is when a shared decision is made. So it's a little bit flipping it backwards from most models of shared decision making, where you start with a medical problem or a decision that needs to be made. The doctors or providers provide some expertise. Then you as a patient get to weigh that against, what your own preferences that maybe you haven't articulated yet, and then you make a decision that you both agree on. This framework sort of starts with the individual, and we think that this is a more consistent framework with a person-centered care. So we conducted a study about, let me pause there before I go into our study of our measure and the tool that we developed. Any questions, thoughts, reactions? Janice, do you have anything you want to add about the sort of framework?
No, I was just gonna say, I don't see anything in the chat, Maria. I just guess what makes me think about when I think about our shared work in the person-centered world is that, when you think about developing treatment plans and even presenting options, there's a phrase that somebody brought to my attention once. And as you know, as a doctor, as a supporter, you can't really know what a person needs until you know what they want, right? So the conversation really has to start with what a person wants and what is the goal and what do they want to get out of the interaction. And very often we jump immediately to what do they need and what do I have to offer, with skipping that part of the model. And that's what I think really kind of sets apart some of the tools and the frameworks that you're talking about today.
Great, thank you. Thank you, excellent point. So this was a PCORI funded study several years ago, where we decided we wanted to develop a shared decision-making tool for persons with chronic illness. And this was because in looking at some of the tools and measures that are out there, they really tend to focus on sort of the process. Was information provided and shared? Did you go over risks and benefits? Did you ask the person what they wanted, and did you arrive at a shared decision? And we decided we wanted to kind of flip that on its head and focus more on the values-driven sort of shared decision-making model. So this is, we've gone over this a little bit, but the background to the study was that really the current models tend to emphasize this collaborative relationship between a practitioner and a patient in making informed treatment decisions. And central to these models is the presumption that people have enough information to identify and choose treatment that is consistent with their values, goals, and preferred states of health. And that information is not all stuff that can be provided from the physician or the provider. That also includes being able to identify and know what's most important to you. And the range of decisions that can or should be made within the context of a shared decision-making process is fairly restricted. Oftentimes it's limited to sort of some predetermined treatment options. Doctors may say, well, we can do X, Y, or Z, and here's the choices. But there actually may be other options, including not receiving treatment, that might be a real option or value for somebody. And while important, these are not necessarily the personal decisions about what are most meaningful to people in their lives. So we set out to change that. And the goal was to improve clinical practice, to enhance services through the development of a tool that can help people identify and communicate their preferences about treatment and health outcomes, starting with the person, and help them make healthcare decisions that are consistent with their preferences, goals, and values. In this research, it had 3 phases. We did qualitative interviews with individuals living with chronic physical and or mental illness for various lengths of time, thinking that people who may have lived longer with a diagnosis might have different values and preferences and goals than somebody who is more recently diagnosed. So that was the first step. We did the qualitative interviews. Then we held what was called statement generation groups with 34 persons living with physical or mental illness. And we asked them 2 questions. What are the areas of your life that are most important to you, that you value, that you hope for, and that give you meaning? And the second follow-up question is, what does a doctor need to know about you in order to provide high quality care? And then the third step was doing an online practitioner survey to find out providers' views on what they needed to know about their patients in order to provide high quality care. And there's the qualitative interviews. I went through that. But here's some of the quotes from those interviews. He asked me a couple questions, and in the qualitative interviews, we asked them to describe or think about a time when they felt really heard or valued by their practitioner, and also a time when they felt maybe less valued and heard by the doctor. He asked me a couple questions, wrote something down, put me on some medication, and pushed me out the door. I think it's really, really important that I control what goes on with me. Don't nobody know my body like me. I make 95% of the decisions. My doctors are just there to listen and tell me what my options are. Every day I'm fine. I can go do regular things that everybody else does. But at night, when I have to prepare myself to take this medication, it's my constant daily reminder that you have a chronic disease with no cure. I have basic state insurance, and I'm not getting consistency from doctors. I'll have a great doctor, but then they'll be there, and then I'll have another one. Nothing is consistent, and that drives me crazy. At first, I went through a period of not trying to accept it. The more and more I would refuse to accept it, the more and more I was hurting myself. So I had to make a decision to do something about it. I just couldn't act as though it didn't exist because I was hurting. Not accepting it caused it to be worse. And in our interviews with physicians about shared decision-making in the process, they said this: giving people the burden of a choice when they are not equipped or don't want it is not necessarily in their best interest. I think it's important to notice that I also have needs in the encounter, in addition to the patient's needs. Legal obligations to my training program, obligations to my own sense of safety, sending someone out into the community. I consider them to be an authority on their daily life and me to be an authority on medical concerns. In some ways, I offer myself as a consultant in that capacity, not an authority like a boss of them, but an authority that is available to them. I used to be attached to my treatment plans because they were evidence-based and bound to be effective. But I've realized that a mediocre plan that's carried out is much better than a perfect plan that's ignored. Janice probably has something to say about that. It would be insane to try to force one option over another given you're not curing them. I still want the treatment plan to reflect what they would want, but not completely, if that's going to be detrimental to them. I know that I'm making a paternalistic decision here, but I think that's acceptable to a certain extent because they are very impaired and unable to make those decisions for themselves. If she wanted a certain brand of dishwashing soap, she was entitled to it. That's the way she felt about Chantix. So you can see a little bit of the different views and some of reluctance, hesitation, concerns about sort of this process of shared decision making here. So the next step in this, and this was a concept mapping project, the next step was to do statement generation groups. And we held these groups with people living with chronic physical or mental illness. And the goal of the statement generation groups was try to identify all the possibilities of things that would be important to people's lives. And we asked people not just with chronic physical mental illness, we also asked people who did not have one of those diagnoses. And the reason we asked this, and some people have questions about this with the concept mapping process, is we wanted to make sure that in a measure that we developed, that we included the realm of possibilities, what things are important to people's lives. And if we only asked people who might be living with an illness or condition or marginalized in another way, their perspective of all the possibilities may be more limited than somebody who doesn't have to live with an illness. So we want to make sure that in developing a measure that asks people to identify preferences, that we included things that they may not have thought about before. So the first question again, we told them a little bit about what we were trying to do just to give it some, orient them to the process. But then we asked, what are the things that are most important to you, that you value, that you hope for, and that give you meaning? What are the most important things to you? Again, second, what does your doctor need to know about you in your life in order to provide you with good care? Here's some of the things that people said when we asked what are hopes, values, and dreams, the important things in your life. They talked about family. They talked about kids. They talked about work. They talked about health, their community, forgiveness, God, fellowship. They did mention doctors. Talked about being clean, learning, children, being a wife, a worker, grandkids. They talked about things that largely didn't have to do with health or their medical decisions. They talked about things that valued in their life that gave them meaning. When we asked them what doctors need to know about me, you see a lot of the same things. There is some addition of they need to know about my medication and history, but this family and what I want and work and life, and that these things are important for people to know. And it's not just doctors just need to know about what medication I take and what my past medical history is, but they need to know about other aspects of my life that are important. And then when we ask what doctors feel they need to know from the provider survey, what do they need to know about their patients in order to provide high quality care? And these are some of the responses. They needed to know about treatment, history, strengths, their health, their goals, their substance use, their physical symptoms, housing. And you can see they're a little different. So up here in this corner, what are most important, the values, goals, what gives people meaning in their life? What do doctors need to know about them? And then here's what doctors said that they think they need to know about their patients in order to provide high quality care. There's some things that are missing. Here. I don't see family. There's a lot. Anyway, this is very telling. And so we wanted to try to change that and see if we could help influence that. So basically, after we generated all of these statements, we had people back and they sorted the statements into piles. We reduced the number of statements to 100. And then everyone came back in person and we gave them packets, each statement was written on a different card. And the rules were to sort them into piles based on similarity. And you couldn't have 100 piles and you couldn't have one pile. So people had to make a decision about which things were similar to one another. And this is a concept map that comes out of, we did a whole hierarchical cluster analysis and other statistical analysis that produces this map. And what we found was that items that are closer together are more similar or more commonly sorted into the same pile. And items that are farther apart were less commonly sorted into the same pile. When we looked at these items, we saw several different themes come out. And remember, these items are based on what is most important to you in your life. Doctors did play an important role. My doctor's role in my healthcare, that was important to people, and they saw that. There were several statements that kind of hung around there. There was also this element of, I have a responsibility for my own health. There's things that I need to do to take care of myself. There's also items about my sense of self and what it means, what's important to me. A lot of these were values, religion, and I'll show you what went into these in a moment. But then there were these relationships, these sort of my connections with others, family members, community members, so forth. This here, it has to do with access to resources, and this was transportation, having health insurance, things like that. Those were important. And then this thing, cluster in the middle, had to do with the type and the way in which care was provided. This is the transactional component of care that's provided that is person-centered. And you'll see these in just a second. Any questions? I know I've ran through that very quickly. Any questions?
Maria, can I, this is Janet, just jumping in with something that's in the chat. Just wondering about, I know that much of this work in the development of the concept map, I think was done primarily with a group of adults experiencing healthcare and living with chronic illnesses. And so the question in the chat is just kind of your thoughts on sort of how shared decision-making applies for kids, about how some of these tools might be able to be applied with kids. Can they also be equally accessible to solicit, you know, the kiddos' perspective? You know, just any kind of thoughts on that.
Sure, sure. I think that that's certainly a question that we see now more than many years ago. I mean, before the parents had, you know, decision-making and healthcare decision-making roles and primary roles in their child's healthcare. Now, we actually see in my chart, once a child turns 13, at least here in Connecticut, I don't have access to my child's health records anymore. And I just found this out, you know, a few weeks ago. But they are given access to their own records and can choose to share with me or not. So there is definitely a shift in prioritizing and considering child and adolescents' views about their healthcare and what's important to them. There certainly are limits. And in terms of risk or things that, if somebody doesn't have the capacity to provide or to make healthcare decisions, but I think that the field is leaning towards trying to sort of involve people in their healthcare decisions at whatever extent they can, no matter the age. And even it says, if somebody does not have the capacity to make healthcare decisions, for example, if an adult has a conservator, they still are talking, the recommendations are to still inquire, to invite, to ask about what an individual's preferences are, and then negotiate with the conservator or somebody else about the best decision. So it's still coming to a shared decision, but this is not limitless. It's not boundless, and there's limits for adults as well. But I think the tools can be used with children, and that would be, or youth, and we could, some of the items may be different, but it'd be very interesting to see.
I think the nice thing about the tools is that, they don't come out of a research algorithm per se, and just only how providers think these questions should be asked. What's nice about the tools that I think makes them particularly accessible is that the concept mapping is really rooted in actually getting the statements from patients, right, across the lifespan. So in that sense, I would think that application of this with kiddos could certainly be, modified.
Absolutely. Absolutely. And I would recommend doing a concept map study with adolescents or youth, because we did not include them in this study. So their responses may look very different, but important to consider. And this tool could be adapted for that. Let me share with you the tool that emerged from this.
Yeah, that'd be great.
Yep. And then I think we'll have time for just one little breakout or exercise. So this is called My Healthcare Map. And each one of these slides here has to do with shows one of the clusters from the concept map. These statements are the statements that were sorted into that cluster. And what we decided was, if we presented this to individuals, and we did a pilot study where we said, we identified people who had an upcoming medical appointment. We sat down with them and said, what do you want most from your doctor today? And then we gave them some ideas, some of the statements that people had told us were important to them. So you're not just starting with, what do you want from your doctor today? Well, I want this medicine that's really tasty, right? Like Jason. It's other people said these things were important to them: to obtain medication that works for me, to be treated as a whole person, to be informed of all options for treatment, to know his or her opinion about the one best treatment, to share his or her knowledge and expertise, to give an accurate diagnosis, to tell me the truth, even if they're uncertain. And you'll see here, not to rush me, to ask me who I want to be involved in my care, to respect my time, and to ask me what I'm most worried about. Remember, these questions were not about shared decision making. The question was, what is most important to you in your life? Now, people living with a chronic mental or physical illness obviously had the vantage point of interacting with healthcare providers, but these things were important to them. We didn't say what's most important in your, in relationship with your doctor. These are the things that came out in the concept mapping. So the way that this tool was used is we had them rank order 1, 2, or 3 in order of importance to them. You could also write in their own. You did not have to identify one of these things. If somebody else was considering something that wasn't on here, then that could be on here as well. The next slide had to do with my responsibilities for my health. What do you need to do or try to do to take care of yourself? And some of the responses were, I need to understand my illness. I need to keep my symptoms under control. Ask questions. Take my medication as prescribed, accept my illness, manage my stress, set my own goals, deal with how my illness affects my emotions. Or again, write in your own options. And this is what we did. We did this with, we piloted it with 15 patients and their doctors. The next aspect has to do with my values, virtues, and core beliefs. What are 3 aspects about yourself that are important to you? Taking care of myself, being trusted by others, being independent, being able to express my worries, fears, and concerns, my physical appearance, fulfilling my responsibilities, having a good relationship, feeling hopeful, and my strength and determination. And this was the aspect that had to do with sort of my resources and challenges. We thought we would ask, instead of saying, what else are you struggling with, but what else is on your mind today? So you're going in to the doctor and you know that your life is not just about this 30-minute or 20-minute appointment. People have other things going on, and people who talked about having housing or worrying about work or education, having responsibilities, transportation issues. But I'm also excited about my hobbies or interests, a new thing I'm doing, my education. So these can be things that people were excited about or that were concerns, but other things on their mind that were salient to them on this day. And then the last slide goes into what else should your doctor know about how you want to receive care or treatment. And this was sort of my person-centered care, the processes. It's important to have a doctor who talks to me in a way that I understand. I need to know what my rights are. I need to be able to advocate for myself. I need to be heard and listened to. I have concerns about my weight. Do not judge me, and so on. So on each of these, they rank ordered 1, 2, or 3, or added their own in. And then what we did is we transferred this into a one-page document where we took their top 3 things in each domain and wrote it out onto this one page and asked them to take this map with them to their next appointment. And they did. And in this study, the practitioners were not informed. They were not participants in the study. These were just the individuals going in and saying, hey, by the way, I have this thing. Would you take a look at it? And so it took the first 2 minutes of their regularly scheduled appointment, and they shared this with their doctor. And here's some of the reactions that people had. Participants said the tool helped me feel like I belonged and had a say. And for the first time, I felt like the appointment was mine. They described this process of literally taking about 2 minutes, sharing this one piece of paper that just kind of highlighted their key things, the most important things in these different areas. It put the ball in my court. Going through all the possibilities made me think about what I really wanted to get out of my appointment. I know doctors cram in appointments and get double booked, so they are rushed. This helped me make the best possible use of my time. I think that it's great. And some of the providers said there's a definite need for these types of programs about how to communicate with your healthcare providers and importance of participating in the treatment. We also had another emergency room physician said that it helped her and especially in a very fast-paced environment like an emergency department where people are coming in and you have to quickly evaluate somebody who may be new to you that you haven't worked with for many years or months. This document helped them to evaluate within the first 2 minutes what would usually take them weeks or months to understand about a person. So it also helped to guide the questions. So this was not a tool to actually dictate the treatment decisions, but it was a way of communicating and sharing an individual's values and preferences and goals with the provider at the onset of the appointment, so that then the provider looked at this and said, oh, I see that you're concerned about making it to your child's school. You have to pick them up at 3 or whatever might be on their mind. And those values then, here's the medical decision that needs to be made. Given your values and preferences that you've just shared with me, here's the options. Now let's talk about a shared decision. And this is where it's a slightly different, a values-based approach. It's slightly different than the shared decision-making models that are largely out there that focus on the individual treatment decision that needs to be made, the information that the medical provider has, sharing that with the person who then makes that decision. This is driven by the values and preferences and goals of the individual. So I see we have some time. Any questions, thoughts, comments?
Maria,
Yeah.
there's a comment that came into the chat, and Vera, I may invite you to unmute. But Vera was asking about, there's a specific bill that has been.
Yeah, you want me to just speak about it?
So Vera, what I said in the chat, let me just say that we're not going to know the specifics of the bill or the implications, but I definitely think that what you're getting at is a question that Maria can speak to, which is that kind of what is the application of shared decision making in the context of programs, Maria, that are more mandated
Mhm.
or court ordered in some way, and to what extent could it still be implemented? So I think that's the general tension, but Vera, go ahead and explain
Yeah,
those specifics.
that that's it. As an advocate and a peer specialist, my personal opinion is that it's against the peer specialist code of ethics, but it's about the person who's being mandated to do this treatment, hopefully voluntarily. And so, how can you implement shared decision making with someone whose capacity may not? I mean, it actually, I don't know that they would be totally incapacitated, but is it possible to still say, this is shared decision making and do the best you can in a bad situation?
I think so. And this has actually come up a lot with the advanced directives and thinking about using them and having patients involved in decisions while they're hospitalized, particularly people who may be hospitalized with mental health conditions that may not have the physical incapacity. So if somebody is in a car accident or in a coma, they obviously can't communicate their preferences. But this comes up if somebody is in a mental state that they may not have capacity to make a decision. One thing about the capacity laws are that decision-making capacity is not an all or nothing thing. That decision-making capacity is really dictated down to the particular decision that is being made. A person may not have the capacity to make a decision about which medication is best for them, perhaps, if they are involuntarily treated, but they do have the capacity to express their preferences about what activities they want to do in the day while they're at the hospital. So decision-making capacity is not all or nothing. It's limited to the particular decision that's being made. And in cases where somebody may be mandated to treatment or in a hospital situation, still what they are saying is you still can go through this process and understand what's most important to you in your life. These things don't require you having capacity because it's not a decision-making tool per se. It's a way to elicit and communicate and share your preferences to people. So anyone can do this process and can be used with them and then look at the situation and say, well, what are the options that we might have available?
Could a judge be, could a judge be, I mean, could this be given to a judge and maybe even in the care court system just so that judges are more aware of how they might be able to speak with someone who's in, standing before them in court?
It's an excellent question, and I think you're tapping into something sort of the next phase of research. We talk about, advanced directives, and right now, if you have a written directive that a judge and a doctor have to sort of take that into consideration, and the same for psychiatric advanced directives, so decisions that are made in advance for people with mental illness. And so in some ways, could this be a tool that could help communicate an individual's preferences, not only to doctors and care providers, but to judges who have to sometimes make a decision about a best course of treatment or a mandated treatment. I don't think it has been tested, and I think that remains to be seen, but I wouldn't put that out of the realm of possibility because especially if you sign it and you have sort of, these are my values, goals, and hopes, you would hope that this could then drive not only treatment planning, but maybe the creation of an advanced directive or helping other people to understand when decisions need to be made, what's most important. So I would absolutely say that it's worth, we don't know if a judge would uphold these things. That remains to be seen.
Would your expertise be available to like a system, county system or a court system, so that you could explain it to them? Because coming from a peer specialist, it's like, yeah, right. But anyways, thank you so much.
Yes, thank you,
Vera,
Laura.
this is Janice talking. I would just say at the end, our contact information from New England MHTTC is included, and feel free to reach out to us with an email. We're always interested in working
Okay,
with all.
great. I love the Pacific Southwest. I mean, all of the cares, all of the MHTCCs, they're great. So yeah, I will retain that information, and I probably will reach out to you, because I advocate also at the state level. So
Great. Well,
yeah,
we look
it's
forward to hearing
important.
from you. Thanks, Vera.
Thank you.
Wonderful, thank you. Any other questions or things that are on your mind before we do one little activity? It won't take too long, but
I'll just point out in the chat, Maria, it's Sarah was kind of pointing out how much she really liked this particular vision. And then like, you hope it doesn't sound simplistic, but even having a family member who carries an allergy list around to restaurants to like make sure you stay safe. And I was just about to type, like, that's not simplistic at all, right? A big part of this model is really getting comfortable enough to be able to articulate what's important to us and what we want other people around us to know about us, right? That can help keep us safe, help, have more positive experiences in healthcare. I think the analogy is spot on.
yep, absolutely.
One part of this is having doctors and healthcare professionals listen with that ear, but the other part of it is getting comfortable and confident actually articulating it, which doesn't always come easy to patients. And I say that myself, having myself been sort of silenced sometime in my own receipt of healthcare. So I appreciate both sides of that.
Absolutely, and I think that that's key. That again, from the shared decision-making model, it's almost taken for granted that physicians or providers or doctors or treatment providers, they have the knowledge and the expertise that they're sharing. And it's almost taken for granted that the individual has actually thought these things through and could, in a 20-minute appointment, weigh the options that are given against their values and hopes and dreams when you haven't really processed that and thought about that. I know it would be extremely difficult for me to go into a medical encounter and be presented with many options, and then I have to weigh them against things. So this exercise is really in how can you not only identify but communicate those, and this communicates it in a way that doesn't take a lot of time. Practitioners can look in the first few minutes, and really what people described, we did the telephone interviews with the doctors afterwards, and they talked about how very quickly they kind of got down to what was most important to the individual, and that helped them in framing their recommendations. So again, the recommendations started getting influenced this way by the values instead of here's what your options are. Now you get to decide which is best for you, but it really does it's driven by the individual. Let me see, there was something else I was going to say on that. Oh, I can't remember, but so one of the things that we thought we would do, and this is up to the group, I don't know how many people are here. Do you want to do the exercise, the breakout groups?
So, Dr. Maria, I just have one question for you.
Oh, yes.
So, Dr. Maria, could you please talk a little bit? We know that your work is recognized nationally and internationally, and we know that you have adaptations about your studies, sharing decision makings, and some tools that you developed. Mm-hmm. Could you explain a little bit about the importance of sharing decision making for the Latinx contacts, providers, and community?
Absolutely. Thank you. One thing I should note is that this research was done on a very diverse group of individuals that did include a significant number of Latinx and Black and Brown individuals. So the other thing, though, that people in our sample, in particular, the statement generation groups, tended to be those that did not necessarily have health insurance or all the resources. So this was a group of individuals who, did not have maybe the same access to resources that others with more, secure jobs or employment or healthcare insurance have. So that does influence some of these things in the statements that come out. We could look at, which we haven't done, but we could look at this group sort of by race or ethnicity to see how the statements or the things that are important to people might differ between groups. I would also say that that's probably really important to do for another study, that we would want to be sure that not that we wouldn't present these things to all individuals. We would want to make sure that we're including statements on this measure that are reflective of values that may be more unique to sort of Latinx populations or other people. So I do think that it could still be used, but I would be cautious because I'm not sure that it includes all of the voices. It includes them in our sample, but I don't know if different items would have stood out as more important. So these aren't all 100 items, right? So in deciding which items made it to the measure, we looked at which ones were most important to the group, not necessarily which ones were most important to men or women or Latinx, or right? So I would recommend making sure that the items on here are reflective. There's a place for people to write in here, which is good. But I still would want to see more and see if it might look different. The concept mapping is a pretty straightforward, easy process. It would be a wonderful study, and I think would be important to, especially if we're thinking about adaptation and use of tools in other populations or other countries. It's not just as simple as taking this and translating it into another language. I don't know if that
I think Maria,
I don't know if that answers it, but
no, I would just add, I think, Grazie, I think your point is really excellent. And as I look at some of the sort of options up on this screen in terms of the questions and whatnot, I think it's absolutely true that how a person feels about those things is culturally mediated, right? Across cultures, and then even in terms of individual variation within cultures. And I just know from some of our similar work in person-centered care in Latinx communities, for example, that a lot of times shared decision-making as a concept and a practice is based on a very sort of a more Western independent decision-making, amplify the voice of the patient. And while many people prefer to have their voice amplified, there's also cultural and individual variations around maybe more collective models of decision-making. And also, I know in some of our previous research with Latinx individuals that people often would say, I really have a trusted relationship with my provider, and I trust them and I trust their authority. And the most important thing for that individual may be that they want the doctor's opinion on what would be the best treatment. Whereas another individual from another culture or just based on individual preference would say, I don't want your opinion at all. I want you to tell me what the options are. And then based on me knowing myself best, I'll make the decision. But many of the Latinx individuals that we've worked with in the past have said that felt perhaps disrespectful of the relationship with the provider. So I think even within some of these items, you see that you're going to see the cultural and individual variation. And we'll be sensitive to that, because whether it's your conceptualization of time, roles in the meeting, how you partner on decisions, all of those things are based on individual preferences. I mean, to me, that's one of the things that I like best about some of these items.
No, I agree. And I think that I'm just saying it would be important to test it out and to make sure. But I do think that they're applicable, particularly in I don't see an item on here, what do you want most from your doctor today? About I want my doctor to communicate with my family member. There's other items that may not be on here. There's place to write those in, but part of it is making this a little bit easier so you don't have to think about it. If you had to sit down and write and think about your next appointment and what is it that you want from your doctor. You think about what are the things that you might say. They may not be these things on this list. And so it is important to have sort of a wide variety and some varied responses. Do you want, should we do the breakout groups, or I don't know if people have other questions or thoughts that, I haven't looked at the chat here, I can see.
One just came in, let me see.
Oh.
The pandemic, there's a,
Yeah,
you see that one?
I do. The pandemic, this has been, I just read an article about this, about shared decision-making in the pandemic. And there were some myths that shared decision-making has to be done in person, that you really have to have, you know, a range of options available in order to do shared decision-making. And the pandemic has really challenged us in figuring out how to work best with one another to ensure that decisions are informed, particularly if you think about the emergency departments and what decisions had to be made at the height of the pandemic about healthcare and how hard it was. And really, does shared decision making go out the window when some may not have resources and options? I would hope not, but I would also hope that there would be a way that that you could incorporate some of that. You know, it's a very touchy subject, I think, particularly when it comes to the emergency room treatment. Yeah.
Maria, just to come back to the potential for an exercise, we had some people that had to jump off early.
Okay.
We have about 9 participants. If we wanted, we could break into 3 groups and just maybe in the groups, take 5 minutes, reflect on the items on this particular slide, just in thinking about in your experience in healthcare as a patient, which of these items are really most powerful to you, most important to you, that really resonate with you, and just sort of compare notes in small groups. I think it's always fascinating to see that different things are important to different people, right? So I think we do have time to do that. If you want to go ahead, we can set it up.
That would be great.
Vanessa, you want to
Yeah, great.
set the breakout groups up?
Okay, so
Yep.
we'll
Should
break
we
out
do
for
that?
about
Maria?
5 or 6 minutes. And again, like Janice said, we'll take a look at the items on this particular slide. Maybe think about an upcoming appointment that you have or a recent doctor's appointment. And Graciela, in thinking about yours, what might be missing on here? What things could you add that would be important for you that might not be on here? I'm curious to hear what really stands out and what people come up with. Okay. Can you hear me?
Yep.
Are we back?
Yep.
I'm just curious. I had the pleasure of speaking with one of you, but I'm curious about what other things came up or thoughts that you had, either about this particular slide or measure or anything in general.
Maria, can you do me a favor? And can you share your screen again? Somehow I lost your slide. I don't know.
Oh, yeah. Okay.
I have a whole job memories, I think.
There we go. I'll get it.
Okay, great. Thank you.
Okay. Very good. Any other dialogues or points? Or I know we've got a few minutes left. I want to make sure that I have time to answer any other questions. And
Well, Graciela had some really interesting comments that I think were really helpful.
do you have a couple of, are they in the chat, Janice, or?
I didn't see anything in the chat.
Oh, well, yeah, in our breakout room, I'm trying to, I don't want to speak for Graciela, so I am suggesting that she speak up because I liked her point.
Thank you.
Oh, Valerie, we can jump in and help, but we have a very nice conversation. We recognize the importance of these questions, but we also have a thought that we'll have more questions relate to this relationship with the doctors or providers, that we can have a previous understand about the treatment, about the plan, about how this applies for you. Some ways that can break a little bit the ice of balance of power when you go to a doctor, because at that point, if you don't feel that there is a trust in the relationship, you can come back or at the time say something to your provider. Maybe we will step back a little bit before we start to go through and see which one of these good questions or things that you can take will make sense to met with your values when you're in treatment. So what it is important. Of course, for the Latinx side, it is important to have questions about the family, how family could be engaged on any kind of treatment, preference for people in the family. That's not all blood family, but friends and other people, the influence of that in the treatment, the trust that you have in your family to say to this or to that, questions related to religion and how does it impact you, and kind of values that you have, family first, break a little bit the barriers that you need most keeping silent about your mental health. Some kind of questions can orient a person to feel confident to speak up.
No, thank you. I think it's definitely warrants further study and actual use, but I also want to comment that in the model that Janice and Anthony, Pablo, and I have kind of been working on and have been developing, really does take it beyond the assessment of the preferences. It does look at relationship issues, but also practical tools of how to apply such things and to make sure that these preferences, values, and goals are included in treatment plans and actually followed throughout the course of care. So Janice, I don't know if you want to say something more with that, but we actually do see this as being one part of the shared decision-making process. And I see it as the initial part, but then we also have tools to help with the implementation. Do you want to say more?
Yeah, I mean, I think I would add to that, to expand on Grazie's important comments. What stood out to me and what Grazie was saying, and which is really critical in this model, is that almost none of the questions that Grazie was saying are important to ask were really about the doctor's medical expertise. They were really about a doctor expressing authentic interest and curiosity in the human being across the table from them. And that, to me, really speaks to the foundation of all of this is the relationship and the connection between a provider and a person. And so that really that's another component of the model that really is foundational, in addition to the questions. And then also, in the model, just thinking about, once you know what is most important to a person, what does it actually look like to respect that and to incorporate it into care? And the field has oftentimes been lacking on those practice guidelines, which is, again, a gap that we are trying to fill as we move forward.
Agreed. Thank you. So there's more to this. There's certainly more to come, and we are happy to provide resources, information, share any of our tools, and to talk with any of you further as time goes on. And hopefully, we're continuing to develop these ideas and models, and but it's not standalone. There's definitely a lot of research that has been gone into these over the last 20 years. So it melts together nicely, which is great. Since Janice is a dear friend of mine, and we've been working together now for 22 years. So it's nice that our interests align.
Thank you everyone for attending our webinar today, and thank you Maria and Janice for the presentation. I am going to put a link in the chat for those of you who are still here with us. If you could please take a moment to fill out this anonymous evaluation, it would be really helpful for us so we can continue to provide these free trainings. And again, this is going to be emailed to everyone who attended. So to those who had to leave a little early, they'll receive this as well. And then just to reiterate, this event is being recorded. It will be posted on our website, and all resources shared today will be sent as well. And then we do have some upcoming events in the month of October. If any of them interest you, please do register. Again, all of our trainings are free. And then if you are unable to attend, everything is recorded and posted on our website, so you can always catch it after the fact. And again, if you do have any questions, you can always email us. I'll put that link or that email address in the chat as well. Do we have any other questions, concerns from the participants?
I just want to say thank you so much. I serve on the California Behavioral Health Planning Council, and it's something that we've been talking about, and we're going to be meeting in October, and we meet quarterly as a body, and so we'll be in Sacramento in October, and I want to just send this information to people just in advance, so maybe we can at least have a little side discussion about these shared decision making, because it's really important, and I'm so happy that I attended. I appreciate all of the comments and the presentation. Thank you.
Thank you very much.
It's
And
great
then-
to have you, Gary. I appreciate the examples and kind of keeping it real in terms of how this impacts people's lives.
Absolutely.
I don't see anything else in the chat, Maria. So I
Okay.
think we hit the questions as we went.
Sounds good. Well, thank you all for spending the afternoon with us so far, and we wish you well and look forward to further discussions. I think that out there. Thank you for
Thank
your
you very
time.
much, Maria.
Yeah.
Thank
take
you so
good-
much.
Take care,
All right.
everyone.
Bye. Take good care.